Welcome back to the Curbsiders. I'm Dr. Matthew Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. And Paul, we are about to talk about some pearls from a great episode on obesity medicine, because this is a big part of what I talk about in clinic every day. I don't know about you, but for me it is.
Yeah, the number of patients that actually, I think, bring up the topic with me has increased exponentially. I think in part because we now have more effective treatments than we've ever had before. So I will often have patients coming in broaching the topic of, medication management. How should I change diet? So it's a conversation I've had much more frequently in the past 5 years than I did, I think, when I was starting out. And I'm not sure if that's because I'm better at talking about it or because patients are more likely to bring it to me, or some combination of those things.
Yeah. And through the show, I've really, had all my training in obesity medicine has been through the show and then just trying it out in clinic, because it wasn't a part of my, we weren't really talking about it in medical school. I think the big change since we graduated medical school was something around 2013. They started calling obesity a chronic disease. So we have to think about it as a chronic disease model. So like diabetes, like high blood pressure, yes, some patients with major lifestyle changes can come off medications, but the majority of patients, they might need some help, and medication might be part of that. So I think, and this is one of my big soapboxes, Paul, and you know this, that in primary care, there's just not, we have to own this. Like, this has to be something that we are good at treating, because there's just not enough people boarded in obesity medicine to handle this. So this is our world. Do you agree?
Yeah, well, yes, 100%. A lot of the medications we should have familiarity with anyway for other reasons. The idea of motivational interviewing should be something that is well within our scope. Like, there's just all the stuff that is, all the tools that we have at our disposal to address obesity as a chronic health issue. Like, we've already had the training to do. So I agree with that 100%.
And Paul, we're going to talk about some medication pearls, but I know you're a physical exam nerd. So let's say that my patient is really upset. They are worried, I'm not losing weight. I'm working out. I'm eating right. I'm not losing weight. Maybe we can show them something else on physical exam that is proving that things are getting better. And
or not. But yeah, I think our expert talked about measuring waist circumference, and he does it in a way that it was not consistent with research methods, but that's not what we're talking about here. So he does waist circumference. He actually does it at the level of the umbilicus, I think, for like studies. And if you're going to be doing it technically, it's somewhere between the hip bone and the umbilicus. It doesn't matter. But the 2 points that he made is just make sure that you have a nice long measuring tape, because a lot of times patients will be like, this won't go around my waist. But if you have like this 12-foot long measuring tape, then you like, believe me, this is going to make it around your waist, which that way you avoid making people feel defeated right out of the gate. And then second of all, it's hard to measure another person that way around the waist unless you're going to be hugging them, which is a weird thing to do the first visit. So he has them actually hold the measuring tape and sort of pirouette, spin in a circle, and then you can kind of just do the measurement as they sort of circle around and make it that way, as opposed to trying to reach around their body, which is just, again, a weird way to sort of start the patient encounter.
Yeah, I love that. And I think it is true. Like, some patients will, if they're working out and they're starting to lose weight and eat better, they might be building muscle. So their weight might be sort of like steady for a little while, but they might actually be losing inches. And that's a way to prove they're losing inches. Now, Paul, the reason so many patients are coming in and asking us about obesity and treatment now is because of it's in the news so much because of the new medications. But Paul, I have a lot of patients come in and say, you know what, I just can't take these medications. I'm nauseous. I'm constipated. Paul, how do we troubleshoot that?
Well, happily, Matt, it hasn't really been an issue for me lately because I've not been able to get any of the medications through the pharmacy. But theoretically, let's say that I am able to do so. There's a lot of anticipatory counseling around the medications that I probably should have been doing, but was not doing as effectively before. And so one of our experts talks about advising just having your portion sizes immediately. Like, don't wait until you feel awful. And people don't really consciously think about their portion sizes really unless you kind of counsel them to do so. So whatever you normally eat, cut that in half to start out and see how you do. And that way it gives them a chance to kind of equilibrate and their delayed gastric emptying and sort of decreased motility, all those things, a chance to catch up. And then also the other flip side of this is constipation can be a really bothersome side effect for these medications, the GLP-1 agonists specifically. And so one of our experts recommended just starting psyllium with the medication, to start a good bowel regimen as you start the medication, so that you're not trying to catch up with the patient's constipation, because that can sometimes be one of the reasons why they would actually self-discontinue it. So I've been a little bit more proactive in terms of my counseling around the GI side effects of the medication.
Yeah. So half portion sizes to prevent the nausea, and start a psyllium fiber supplement and make sure they have some sort of rescue laxative because of constipation. Because I've had a couple patients, even on low doses, say they were, almost going to the ER because they were so constipated. And I think that's a big thing. The other thing is, and this has been, some patients have lost so much weight, or they just have such a little appetite when they're taking the medications that they're almost like wasting away. And when you lose weight, you lose both muscle and fat. So you really should do resistance training at least twice a week, and do some sort of exercise just to maintain your muscle mass, because you don't want to be like frail and still have this extra weight where you're just like, you're still going to have a lot of fat mass around and you're losing muscle mass. It's a bad combination. So make sure, I do tell patients that they should be exercising and they should do some sort of resistance training along with it. So we talked about a lot of great stuff on this episode with Dr. Cajuni. So you can click on the link in the transcript below if you would like to hear the full episode. I would highly recommend it. But with all that, until next time, this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole. Paul?
Right for your brain hole, man.
Until next time.
I didn't like that. Yeah, that didn't sit well with me.
I've been Dr. Matthew Frank Watto.
And as always, remain Dr. Paul Nelson Williams. Thank you and goodbye.